Hello?
Hello.
Yeah, can you hear me?
Yeah, you want to put your camera on?
I cannot because I'm not in the bill list.
Okay. Okay. I tried to get you in. You don't want to come in? I admitted you. Okay. I'll try again. It says you don't want to come in. Go ahead. Come
Again,
in.
again, I cannot see it. Sorry.
Hey, your camera is not on and you're still not in. Oh, you're in. No, you're not in.
In, but
I'm
my screen is not showing camera.
I'll tell you, you want to come in? I want you to meet Ahmed.
Yes, sure.
I mean, can you add me to the bill list
You don't have
because
time, Ahmed. I want you to meet Atta.
sorry, John, can you add me to the bill list, please?
Yeah. I want you to meet Atta.
Oh.
He's part of the team. Okay, Arthur, come on in.
I'm not getting this option.
Oh, you're not getting the,
Did you send that?
okay, you gotta learn how to use this Zoom. I mean, you really gotta try everything. Uh, I'll tell you, you need to put your camera on.
Okay, now I'm.
I don't know what it is about people. They don't like putting the camera on. What's the big deal? It's like being on the street and you put a hood on.
No, it will be on in few seconds. It will be on.
Yeah, I hear you. Your audio is fine.
Yeah.
Abdel, I'm trying to make you a panelist. I'm asking you to come in and it says you refuse. Abdel, I don't know, something's going on. It says you declined to become a panelist.
Now,
Yeah, I'm trying to get you in, Abdel, and it's okay. Now it says you're rejoining.
yeah.
So you were screwing up, not me.
Okay.
Okay, I'm Ed. Good, you're on the camera.
Hey,
Abdel's on the
good,
camera.
good,
How you guys doing?
good evening, everyone. How are you?
Hey, you're kicking ass. You're kicking ass, Abdel. You probably don't know what that means, but
Uh,
it means we're doing well. I want you to meet Atta. Atta, put your camera on. Can you put your camera on? Or
Yeah.
okay.
I'd like you to meet a guy that's going to be big in the Arab uh, neurosurgery education, Ahmed Ghanemi. He's been doing this
Yeah,
for
yeah,
a couple of
Yeah,
years, right? You've been doing this for like 2 or 3 years.
yeah. That's absolutely correct. It was, I think, the first webinar was with Professor Ibrahim Speh. It was, I think, in 2021. So I think it's 4 years now.
Yeah, that's when Salim was more involved.
For sure. Professor
Yeah.
Salim also is a mentor for us, and he appreciated our efforts and tried to join us many
Yeah,
times.
well, you're picking up the slack. You're picking up the slack, and we appreciate it in the neurosurgery community. I'd like you to meet Atta Bata. He's originally from Pakistan, now in Switzerland. He's a dual neurosurgeon, and he's going to be doing a fair amount of webcasting, as much as he
Mm-hmm.
can. Of course, he's got his life too.
Yeah.
Say
Absolutely.
hi, Atta. You're muted.
Okay. Hi. Hi,
Hi,
everyone.
hi,
Yeah.
doctor.
Good.
Uh,
Atabati.
where are you from, sir?
Originally, I'm from Pakistan.
I think we are in contact in WhatsApp. Is that correct?
Yeah, I guess, yes.
Yeah, yeah. I think there you told me about Yemen in your surgeon that was in
Yeah,
Pakistan,
exactly.
I think.
Abdullah. Abdullah.
Yeah, 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 for sure. You know, he is now very excellent, and I was with him for many
Okay.
months. I think
Okay.
now he is a number one neurosurgeon in Yemen, by the way.
Yeah, he's very famous. So, what about you?
Still try to get an opportunity in another country in neurosurgery
So,
training.
are you a neurosurgeon or?
I'm just trying to get an opportunity for neurosurgery residency in another country rather than Yemen, I mean.
Okay.
So I'm not officially a resident yet.
Yeah, well, you won't be
But
involved much then, but we'll talk about that later.
yeah, yeah, sure.
Anyways, Ata, we're really gonna try to push the dual neurosurgery concept. And
Yeah,
I just was lucky to run into Ata that
yeah,
wanted to kind of do the same thing. I just had a feeling it was getting hot as far as the topic and people,
yeah,
and it just makes sense. I mean,
yeah, yeah,
even to a non-neurosurgeon, it just makes sense. Know how to
yeah,
do
sure.
two things rather than just one. You know, it just makes sense. So we're jumping on that wagon, and we're gonna have hopefully one per week with various groups. And Otto will have one
Mhm.
night for the
Yeah,
month.
yeah,
And we have a nurse from India. He's going to do it once a month. So we'll get various dual neurosurgery groups involved.
uh,
That's the best way to go for it. You don't have to
absolutely.
build it, you already get the community kind of, it's tough to start communities now. You
Yeah,
know
yeah,
what
yeah.
it's like. You know what it's like. It's not everyone likes to do it or likes to answer or whatever. And so,
Uh, sure, sure. I think as a juniors, we need support and guidance from neurosurgeons, like for example, Dr. Atta. Uh, that is the key to develop our activities and to get much more better day by day. So I think we need to get collaborative activities with each other and to have a connection with each other uh, and organize our activities in your surgical TV. I mean, this will help both of us to get much more better and to develop our team day by day and I mean, to get better skills for all of us.
well, how's Dubai going? Is that doing okay as far as response? That's a big conference you're promoting now, right? Dubai?
Uh, sorry,
Uh,
sorry, what did you say?
You're promoting Dubai, right? Dubai?
Yeah, yeah, yeah. Absolutely, absolutely. It will be, I think, the first event of its kind in the Middle East. So,
Why don't you share it? Can you quickly share it right now?
sure what?
Yeah,
Okay, just a minute.
Show Atta the conference in Dubai. It's quite
Yeah, yeah,
large, right? Because
absolutely,
really, we
absolutely.
have to get the Arab community more involved.
Yeah,
They're just, I mean, you're involved in SAMA, but that's not much else. So we'd like to get more of the Arab part of the world.
okay, just a minute. I'm gonna show you screen. Okay. Well, how we have, WFNS.org. Now we have, sorry, just a minute, sorry.
December 1st to the 5th.
Yeah, there we go. This is the home page for the conference. And here there are, sorry, I'm gonna make it. Okay, how you can see this application.
Who is hosting it?
Emirates, University of American, Neurosurgery Society.
Excuse me, Ahmed, have you talked to both the speakers?
So, sorry.
Okay.
They confirmed they're
He
coming?
will join after 5 minutes.
Okay,
Okay.
so you are in contact with them?
Hmm.
Where you can, I don't know if you can. Here is the organizing committee. I don't know if you know any of them. Here is I am. And here we can talk about the belief in this AC. In this conference, by the way, there will be, election for the belief in this, presidency. Sorry, and this will, I mean, till now I know just three of them, and many of neurosurgery societies countries, will candidate for the membership of the WFNS. So this event, as I said, will be the first event of its kind in the Middle East and in the Arab world. And
Okay, I
yeah,
see them coming in. Hey, I hope you guys noticed I changed that picture because man, he looked fat.
Hmm.
Let's see here. Okay, trying to get again. He's declining to come in. What's going on? It must be the platform or something. Because I'm asking him to come into the panel, but it says he declines. Oh, he's coming in now. Perhaps he just didn't know. Okay, our speakers are both here, correct?
Yes.
Yes,
Ahmed Najib Taha.
yes, I am here.
Okay, Mohammed, could you please open your camera?
Sure. It's open right now.
Okay, Mohammed, you want to open your camera, please? Also, the other speaker, Ahmed Naguib,
Yes, it's me.
could you open there you go, your camera's coming
Yeah,
on.
it's open. It's open right now.
Okay, let's see. I'm not seeing you yet.
I don't know why.
You may have to reboot it, like click it on, click it off type thing. Okay. Muhammad and Ahmed Naguib, Dr. Taha, you have to turn your cameras on.
Yeah, it's turn it on. Yes, sure.
It's not on.
I'm sorry. I don't know why.
You can see, right? You can see what I'm seeing?
Yeah, I'm seeing you.
Yeah, I don't see you though. Okay, click it, go to the camera, the video camera at the bottom left, and kind of flick it on and off. Like take it off the camera, then put it back on. You know what I mean? Yeah, it's better go to the menu. Okay, when you open up the menu, it says adjust background. Or you can just click on the camera and then click off it. See, okay, see how you see my picture now, correct?
Yes, I see your picture.
Okay, I'm clicking the camera and it goes off. So you're gonna go to the bottom left corner and click on the camera.
I'm clicking on it. Sorry. I'm sorry, there is some problem. I don't know.
Reboot your computer and come back, okay? Turn off the computer completely and come back,
Okay,
okay?
okay,
And we're here, we're not going anywhere. Completely off, Dr. Taha. Turn it off the
okay.
computer completely. And the other presenter, where's he? Is he here?
another presenter, Prof. Ahmed Alam, cannot present his topic because he very busy.
No, Zoom made some kind of change. It's gotten strange. Because this is not the only webcast where people have declined to come in, even though they're speakers. And I'm trying to get them in. There's some kind of bug or something.
Correct,
At any rate,
correct.
we'll just be patient and wait. Once they come back, try again. Okay, let me get the link to download. Okay.
Hira Burhan.
Okay, I'm putting in the chat. You may need to download the latest version of Zoom, which I'll click here. Maybe I can share it. Okay, good. You can see it. Do you see this?
Where is it?
The link is up on top. You see it here? Zoom.us/download. If you don't do it now, but you should update it. For some reason, we're having some bugs or something. But if you go to the download center, it's a really fast download, like 3 minutes. Because they added AI to the Zoom platform, and that may be causing some problems. That's going to be used, and I tell that to everyone. AI companion. It's in all the paid Zoom accounts. which is, I don't know if they have that in the free version, but if you're paid, you can use, it's like having Chat GTP, but it's easy to access. It's on the right side where the panel box is. And you can go to AI and ask questions about the presentation. You can ask, see who the neurosurgeon is, where he practices, whatever. Without leaving the screen, that's the beautiful thing about it. You don't have to go to another website, or I used to have to check another computer if I wanted to
افتح الكاميرا ازاي؟
check chat GTP. Okay, Nagiba, you're back in. Okay, do you have that camera option on the left, on the bottom?
I am trying to enter.
Yeah, Ahmed, Nagib, Dr. Taha?
Yes,
Yeah,
yes, I'm here.
okay, try clicking on the camera at the bottom left.
Yes, I am. I just click on it.
It's not, I still don't see you. Okay, now you may need to download the latest version of Zoom. Do you hear me, Dr.?
Yes, I hear you.
Okay, I'm sharing the screen now. And this is where you need to you go to zoom.us/download. It's a quick download. You can do that right now. Download it now. You don't have to leave. Are you trying that?
Yes, I'm trying.
Good. Let us know the progress or lack thereof. And the other speaker, do they have the latest version of Zoom? Hello, Ahmed, could you facilitate this conversation?
Sorry, what did you say?
Yeah, the other speaker, is their camera working or no?
Abdurrahman, have you talked with Dr. Ahmed Alam or not yet?
Yeah, I talked to Dr. Taha. He
Yes, I am Dr. Taha, but
Okay. Did you download that?
downloaded the last version. I'm trying to download it.
Sure.
Abdurrahman, did you talk with Dr. Ahmed Alam or not yet? Abdurrahman,
Yes, yes.
so
Prof. Ahmed Allam cannot present the topic because he performed emergency operation.
okay.
Okay. How you doing, Dr. Taha?
I'm sorry, I cannot fix the problem.
Okay, did you download the new Zoom update? Okay, Dr.
No,
Taha, did you download?
I
I'm sorry, did you download the Zoom latest version of Zoom? Hello, is anybody else hearing me?
Yes, your voice is clear, audible. There's no problem with the.
Dr. Taha, are you there?
yes, I am there.
Okay, so have you downloaded?
I opened it on my phone.
I'm sorry.
Good, it works. It works now. It works now.
Oh, there you are. There you are. Okay, all right. We can start. Okay,
Yes.
very good. Okay. Ahmed, are you ready?
I'm ready, but I think Abdurrahman should introduce him or me.
Okay, the next speaker, is he in here now?
He will not join us.
Oh, so we have one presentation.
Okay, I'm gonna start
Okay,
introducing
hold on. Are you
doctor, and then
are you ready to start?
yeah, sure, go ahead.
Okay, here we go. 10, 9, 8, 7, 6. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach. We have today the Yemen Neurosurgery Society led by Ahmed Al-Ghanemi. He has a presentation. He's going to introduce the speaker. Good day, Ahmed. It's all yours.
Thank you, Mr. John, for having this webinar with you. It's my honor to host Dr. Ahmed Najib. First of all, let me introduce myself. Here's Ahmed Al-Ghami, the president of Walter Eden Diagnostical Club of Yemen. I'm also the special assistant to the global president of Walter Eden Diagnostical Society globally. Abdurrahman, I would like to give microphone to Abdurrahman in order to introduce the speaker. Abdurrahman, it's yours.
Okay. 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 Walter turned the Yemen and a Haitian medical student are honored to present Prof. Ahmed Najib Taha, clinical professor, Department of Neurosurgery, Mansoura University, Egypt. He fellowship in Arkansas University. Will talk about peritoneal peritoneal approach, anatomical and technical considerations.
Yes, it's my pleasure to be with you.
Okay, you want to make a presentation mode, correct?
Yes,
Okay, please do that.
the presentation is apparent on.
Okay,
Now?
perfect, perfect.
Perfect, yes. It is my pleasure to be with you to speak about the terminal approach, anatomical and technical consideration. The terminal approach, which is popularized by Professor Yazargil, is one of the fundamental approach for the neurosurgical practice. Sadly, we lost our great professor last month before he complete 100 years. It is my pleasure and my honor to be with him for 1.5 years in Little Rock, Arkansas, and enjoyed seeing his operation and listening to his wise experience. The terminal approach provides enhancing exposure of deep neurovascular structure, minimizing brain retraction, and allow easily vascular control. And proper understanding of the skull-base anatomy is the key for any successful skull-base procedure. And we have to be minimal invasive to the brain, not to the bone. So the concept of moving the bone away and leaving the brain alone is the basic of modern skull-base surgery. So what is the pterion? The pterion is defined as the anatomical region formed by the approximation of 4 cranial bones: the sphenoid bone, the parietal bone, and the frontal bone, and the temporal bone. And here, this is an image that's showing the location of the pterion in between these 4 important bones. So there is many key steps in for the terminal approach. The initial is the patient positioning, and for sure the patient usually in the supine position, always in the supine position with ipsilateral elevated shoulder, and the head rotated 30 to 45 degrees to contralateral to the side of the lesion. We need mild extension to elevate the frontal lobe and align the sphenoid parallel to the floor. and the bringing the Miller eminence to the highest point. And this is a view for the positioning of the patient with terminal aborts, but not in every case has the same position. We need to adjust the position according to the target pathology. For example, with in-head rotation, we need minimal rotation if we are going for midline pathology, and the more rotation when we go for lateral pathologies. And for head extension, we can do head extension in the neutral position when we are doing MCA aneurysm or lateral lesion and orbital tumor, but we need moderate extension for cellular and supracellular tumor, and when we have tumors extending into the third ventricle like craniopharyngioma, we may need marked extension. And this is some approaches, variability in the approaches for middle cerebral aneurysm. We need 30 to 45 contralateral head rotation and mild neck extension. But when are going for anterior communicating artery aneurysm, we need extension for 15 degrees and mild to moderate extension. The incision, it could be curvilinear incision starting half and to 1 centimeter and to the tragus. And we need to preserve the superficial temporal artery and the facial nerve branch. And here, this is a view that shows that the branch of the facial nerve passed 2 centimeters in front of the tragus, and the anterior division and the posterior and the frontal division and the parietal division of the superficial temporal artery. And we need to preserve it because this keeps the integrity and vascularization of the flap. And sometimes in certain cases of bypass operation, we need the superficial temporal artery fluid during just such bypass. And the frontal branch of the facial pass 2 centimeters in front of the tragus, and we need to preserve it during the skin flap. And how to preserve the facial nerve? We have several techniques to preserve the facial nerve. This is the anatomical course of the facial nerve in front of the temporal branch of the temporal artery. And we have what's called interfacial technique. The temporal fascia, it has a superficial layer and deep layer, and the facial nerve runs in between of them. So we have what's called interfacial technique. We dissect the facial nerve in the bed of fat, in interfacial bed of fat, preserving it and keeping the deep layer of the superficial temporal fascia. Another technique is called the subfacial technique. We open both the 2 layers of the temporal fascia and exposing the muscle, and this is extremely helpful when we're doing cranio-orbitozygomatic approach. And here we exposing the muscle. Another technique is submuscular technique. We open both the fascia and the muscle up to the bone and elevating the muscle with the fascia, preserving the facial nerve. So we have 3 techniques for facial nerve preservation, including the interfacial, subfacial, and submuscular technique. The second step for the terminal approach, we have to preserve the integrity of the temporalis muscle by careful dissection of the muscle, avoiding excessive cautery, preserving the deep temporal fascia, which have the blood supply to the temporalis muscle, and avoid excessive coagulation and avoid monopolar cautery to prevent muscular atrophy. Sometimes we can keep a cuff of the temporal fascia for reconstruction and closure, and sometimes we can elevate the muscle totally. Regarding the craniotomy, we have to put the keeper hole initial keeper hole, which is very important for the terminal approach. Proper placement of the keeper hole, it helps us to optimize access, minimize complication like frontal sinus injury, dural injury, and orbital injury. And we have 2 types of keeper holes. The dandy keeper hole, which is for the standard terminal approach. And this dandy keeper hole, it is just below the superior temporal line, above the frontozygomatic suture and above the frontosphenoidal suture. It is 1 centimeter above the McCarthy keeper hole. And here, this keeper hole, if we open this, we will expose only the frontal dura. Another keeper hole, it's called the McCarthy keeper hole, and this is for orbitozygomatic approach, because this keeper hole lies just behind the frontozygomatic suture, When we open this burr hole, we will open the periorbita, expose the periorbita, expose the frontal dura, and in between we will have the roof of the orbit. Then the next step is bone flap elevation. We have to do multiple burr holes in the frontal, parietal, and the temporal, and then we open the craniotomy flap, exposing the dura and the lesser wing of sphenoid, and then we have to drill the lesser wing of sphenoid to expand our exposure, and then when we open the dura, we don't need many extensive brain retraction. The dural opening, most of the time we open the dura in curvilinear fashion, exposing the frontal lobe and the temporal lobe. As we see here, we don't need a lot of retraction, brain retraction to expose the important structure, but we need to do sylvian fissure opening and basal cistern dissection. When you open the sylvian fissure, we expand our exposure to the deep important structure. We can see the optic nerve bilateral, the chiasm, the lamina terminalis, the internal carotid artery, the A1 and the M1. But and also we need to do dissection of the basal cistern to release CSF and to enhance the exposure. But we don't need to drain much CSF, especially when we are operating on meningioma, because CSF is very important to us to help in dissection of the pathology. So we have additional steps. We don't usually need them in all cases, but sometimes you need to do anteroclinoidectomy and optic canal unroofing, and for sure this should be done under the microscope. So this is critical step in certain skull-based surgery for certain aneurysm and certain anterior skull-based tumors. But we need to have some anatomical consideration regarding the anteroclinoid. The anteroclinoid lies here, lateral to the optic canal, and medial to the superior orbital fissure, and it is attached to the sphenoid sinus through the optic strut. And underneath the anteroclinoid breast, we have the clinoidal segment of the internal carotid artery. For sure, we also have certain anatomical variation in the anteroclinoid breast that may hinder, or we have to be careful about this variation to minimize or prevent certain complication. One of these important anatomical variations that the anteroclinoid itself is attached to the middle clinoid with a ring forming a ring around the internal carotid artery. Extradural drilling without knowing this anatomical variation may end with carotid artery injury. So we need to do CT before the surgery to know if we have this anatomical variation, so we can do either extradural with intradural, or we can do intradural anteroclinoid. Another anatomical variation that we may have elongated anteroclinoid. So the anteroclinoid is attached with a bony bridge to the posterior clinoid, and this is also tricky. If we are doing an extradural anteroclinoidectomy, we have to be very careful not to injure the internal carotid artery. So this some osseous variation of the anteroclinoid process. We may have pneumatized anteroclinoid process, and if we drill the anteroclinoid to the strut, then this patient may have CSF leakage after surgery, and we in the form of CSF rhinuria, and we have to be very careful about this problem, and this may lead to certain complication post-operative. As I had said, the corticoclinoid foramen, we need to do perioperative CT scan to rule out this problem, and also the elongated anteroclinoid process. So we can do extradural anteroclinoidectomy, intradural anteroclinoidectomy, or combined approach. This is depend on the surgeon peripheral, but we have to be careful about certain anatomical variations, as I have said. But there is some safe drilling technique. Usually we have to use diamond drill, not cutting drill, with capacious irrigation to avoid thermal injury, especially to the optic nerve or to the third nerve. Also, we need to do low-speed drilling and we need to begin with thinning out the anterior clinoid process, then proceed with egg shell removal. For intradural anterior clinoidectomy, we can start with unroofing the optic canal, and we release the optic nerve by opening the falciform ligament, so to minimize any injury during anterior clinoidectomy. Also, if I'm going to drill the optic foramen, I need to drill it parallel to the optic nerve from medial to lateral to avoid any injury to the optic nerve. So this is an example of extradural anterior clinoidectomy. Here is the anterior clinoid, lesser wing of sphenoid. We expose the temporal dura, superior orbital fissure, and this is the frontal dura. Then I can do extradural anterior clinoidectomy. So anterior clinoidectomy with optic canal unroofing, it allows safe manipulation and handling of the optic nerve. It increases the surgical corridor through the opticocarotid angle, and it is very important for certain supracellular tumor like meningioma when there is optic canal involvement. So here is the exposure. We can see the anterior clinoid optic nerve on the right side, left optic nerve, internal carotid artery, anterior cerebral artery. And then after anterior clinoidectomy, we can open the falciform ligament and release the optic nerve. So I can handle and manipulate the optic nerve without any trauma, and I can open the opticocarotid corridor. Here, after opening the falciform ligament, so I can easily manipulate the optic nerve without manipulating its blood supply, which is coming from the medial aspect of the internal carotid artery, the superior hypophyseal, which is the sole blood supply to the optic chiasm. So any injury or any coarse manipulation here, we can end with ischemia of the optic nerve. This is how the corridor is expanded after anterior clinoidectomy. We can open here the opticocarotid corridor, and you can work here, especially in some cases of craniopharyngioma, and I can also work lateral to the internal carotid artery between the carotid artery and the third nerve. This is our paper with Professor Mifti on meningioma involving the optic canal. So in certain cases, even if it's a small meningioma of the anterior cranial fossa or the cellular region, this tumor can extend into the optic foramen. And here we should open the falciform ligament, and then unroofing the optic canal, we can see the tumor inside the optic canal. So removal of the tumor inside the canal is an important step for optic nerve decompression and improving the visual recovery. Anterior clinoidectomy is not without complication, and it's not without risk, and we should be aware about this risk. And it's like optic nerve injury, either by thermal damage or direct trauma. So to prevent it, we need capacious irrigation, diamond drilling at low power, and drill parallel, not transverse on the nerve. Carotid artery injury, it can happen by drilling, and we have to do perioperative CT to check for any anatomical variation that may lead to carotid injury. CSF leaks through either the strut or through the ethmoid, and we need to be aware of this problem and do proper reconstruction with closure in order to prevent CSF rhinorrhea. Third nerve palsy, it can happen with thermal injury. So we have to do our drilling carefully and avoid excessive cauterization. Now, there is what's called extended terminal approach. This is getting more popularity in our practice. It involves extension of the craniotomy by doing osteotomy along the sphenoid wing, exposing the superior orbital fissure, and drilling the orbital roof to flatten its surface and expand the exposure via the subfrontal corridor. This is offer a more favorable working angle for instrument, facilitating complete maneuverability and the procedures such as aneurysm clipping and resecting certain tumor. This is how we do the extended terminal approach. This is midway between the terminal approach and the orbitozygomatic approach. And in certain cases, we don't need to do an extensive procedure like orbitozygomatic approach. So we can use the extended terminal approach instead of it. And this is very simple for us, but we just open the lesser wing of sphenoid, exposing the meningo-orbital band, releasing the temporal ball, and showing the superior orbital fissure, and we can drill and flatten the orbital roof. So when we open the dura and the corridor is expanded for us more than the classic terminal approach. And this is how is the exposure after extended terminal approach. The exposure is more wide. We can see the tissue. Here is the optic, both optic, the chiasm, the carotid artery, its branches, and this expand our exposure more than the classic terminal approach. This is an example of some cases we did through both the terminal or the extended terminal approach. This is a supracellular tumor, and we did total removal of the tumor with these approaches. Another case of large supracellular tumor. In this case, we need to do more extension to get to the upper part of the tumor, more exposed without need for extensive retraction of the frontal lobe. And this is the post-operative with total removal of the tumor. This is another case of supracellular tumor that was operated upon through extended terminal approach with total removal of the tumor. For me, closure is as important as opening the opening. We need to do sealing the dura watertight fashion. We need to do reconstruction of the skull base when we did extensive drilling. We sometimes need a vascularized flap. We need to have some fats from the abdomen, and to minimize any morbidity after surgery. And thank you for listening.
Thank you, dear professor. It was really so impressive and amazing topic. So, first of all, I would like just to know if there is anyone want to ask you about this topic.
Okay. Thank you very much, Prof. Ahmed Najib Taha, for excellent presentation. I have some question.
Yes, for sure. For sure, you can ask your question.
1 minute.
That's it. Make us wait. Heighten the drama.
What?
No, just joking.
Yeah, okay.
Heightening the effect. Anyway, are we ready? Are we ready?
Let me ask the question.
Recording
Okay,
in
can I
progress.
ask? Hello, John? Hello, John, can you hear me?
I am listening.
Somebody has a YouTube channel open.
Any question?
Yeah, now should I ask the question, John?
Yes.
Anyway, which is the dominant side to have, terminal approach, either the dominant hemisphere or non-dominant hemisphere, and what is the situation to in which that we, to prefer, right side and in other cases left side. So I need to know much more about this.
Yeah. For me, I usually do from the right side. So if the tumor is midline, no extensive paracellular extension So I go from the right side. But if the tumor has a left paracellular extension, then for that time, I will prefer to go from the left side.
So, is there any contraindication in this case? I mean, to have about the side of the terminal approach?
No contraindication for either right or left, but my preference,
Mm.
I prefer to to go from the right side if it is feasible. But if in some cases, if I need to remove a tumor in the left paracellular region, then I will go from the left side.
Okay, thank you.
Okay, I think Ata Bhatti has a question. Go ahead, Ata.
Yeah, excellent presentation. Sorry, Dr. Abdul Rahman.
Yes.
Okay. Do you want to ask a
I
question?
am very sorry. He can't or one question in the surgical management population in the cavernous sinus. Uh, how does how does related understanding of the microsurgical anatomy of the cavernous sinus included the relationships of of cranial nerve, internal carotid artery, and oral layer influence surgical approach selection and minimize neurological morbidity.
For me, if the tumor is extended to the cavernous sinus, I usually don't go to the cavernous sinus to remove the tumor inside. So if I have a tumor with paracellular extension with cavernous sinus involvement, I remove the extra cavernous part of the tumor and then I will ask for gamma knife for the residual part in the cavernous sinus.
Okay. Thank you very much for excellent presentation. We are very proud to meet with you.
Thank you very much. Any more question?
Yeah, Dr. Ahmad Najim, I have some comments. It's
Okay.
a question. Excellent presentation. And, we know that perineal craniotomy is versatile. It's like a workhorse for neurosurgeons working in many approaches in the anterior circulation, vascular diseases, cellular, supracellular approaches, a lot of anterior cranial fossa, orbital approaches as well. So it's a versatile. So my take is a lot of complications or happens secondary to venous problems, and many of times people are not ready to do pre-operative understanding of venous system. So suppose
Yes.
if there are dural venous sinuses or DVS or any abnormality or dominant drainage patterns from the middle cerebral veins, if you miss that, you end up with the complications. So what we see in a mediocre comment is that we did the excellent surgery, patient was all right, but something happened after 24 hours. The classic venous complications. So any advice do you want to give to juniors and how to plan the perineal craniotomy in terms of venous understanding? Thank you.
So the problem usually with venous problem here, it happens when you are going to open the sylvian fissure. When we release the temporal ball and we sphenoparietal veins and we open the sylvian fissure and sylvian vein. So you have to be very, very careful with sylvian fissure dissection and try to avoid violation of the venous structure at this area, because this is the time which you may have problem with the venous congestion, venous edema. So you have to be very careful not to coagulate veins where you are opening the sylvian fissure.
Okay, let me just put it in a different way, that if you are planning for a cellar supracellular region, and what preoperative workup would you essentially recommend?
The classic workup, for every case, we do an MRI, MRA, and MRV. Sometimes, in some cases, vascular case, we do CT angiography to rule out any vascular problem, whether arterial or venous, for proceeding for the approach.
Thank you. Yeah, I totally agree.
Thank you.
Thank you.
Okay, Ahmed.
Yes.
Ahmed,
Should I wrap up the webinar? Any question? Is there any question? Let me check there, I think. Okay, if there is anyone
I think we're all
has a
caught up
question,
there. We're all
raise
caught
your
up.
hand. Anyway, I want to just say that to Dr. We are so happy to have this webinar with you. I'm so excited and motivated to have likewise webinar with you in the coming few weeks, as this today webinar, I mean, was very impressive and was very beneficial. So thank you for this, and I hope to have you again with us more than one time. And personally, I need to, I mean, I wish I can meet you soon, inshallah, in Cairo or in Egypt and all. So I hope so,
I will be happy for this.
It's my
Thank
honor.
you very much. Thank you very much.
Thank you, thank you,
Good.
dear. and
Thanks,
thank you,
everyone. And thank you,
Thank you, John.
Yemen, and we'll see you soon.
Thank you very much.
Thank you, thank you, thank you.
Thank you very much.